Well, shall we get started? Open the meeting. We join you in the Pledge of Allegiance. Put your reaction over there. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. First item on the agenda is public comment. And sir, would you just state your name and...
Okay. My name is Orlando Gonzalez, and we're here in Lakeview. And I have a couple of comments. One's a real easy one, and then the other one, little, I don't know what you might call it, might be controversial. But I don't need an answer. I just have some questions, one recommendation, one question.
Okay.
So I don't need an answer tonight. I just leave that with you, and then whatever you can think about it, or say, hey, you don't need to worry about that.
You bet. Fire away.
Okay. One thing that I've been meaning to come and chat with you folks around out in the lobby, there's 4 posters, and it demonstrates the harmful effects of marijuana, cocaine, meth,
Yep.
and tobacco.
Yes.
And one thing, I've always noticed that, and I've said, what's missing? Alcohol. And the reason I bring alcohol up is, I think during past health evaluations of Lake County, that's been one of the concerns, is alcohol. There's a problem there, and I know individuals here in the county that are affected by alcohol. It affects their health. They're over here to the hospital because of that. And I think you folks realize that also. And I was just wondering, that's one thing, that's a recommendation, maybe you might want to consider putting one up there for alcohol. Because it's almost as bad as some of these others. It's a killer.
That's an excellent point. That's a good idea.
So anyway, that's one. So anyway, that's for your consideration. The other one is a concern by myself as a private citizen. And again, this is hearsay. So I may be completely off base, but if I am, I'm sorry. And like I said, I don't need an answer tonight. And if you want to chase me out, you can. Okay. But anyways, this past, I think it was Tuesday or Monday, Senator Merkley was here. Okay. During that day, I received a note by another individual, unknown to me. I don't have my identity or whatever. But supposedly, this individual works here at the hospital. I think it was an employee, I'm not sure. But and I don't know if it's a she or a he, but anyway, what they stated in this message was that the CEO of the hospital had a meeting with some employees, I don't know what group it was, and basically mentioned that Merkley was going to be here. Senator Merkley was going to be here. And that and I guess, like I said, it's hearsay, that he encouraged people to attend the meeting because he stated, it was hearsay, he stated that Merkley was against Measure 43, which is the measure that some people who started up in Portland asking to be put on the vote in November to ban assault weapons and large clips, etc. So anyway, I don't know what the policy is in regards to giving instructions to the employees in regards to policies, candidates, or whatever. But it was a concern, if it did occur, that the only background I have is basically I worked for the government and we had a Hatch Act. I was covered by the Hatch Act. And I couldn't do things like that. I could, and so I don't know what your policy is, and I just wanted to bring that to your attention. Anyway, you can think about it, and thank you very much for your time.
You bet.
Okay, thank you.
John, if you'd like to respond to that.
Sure, and everyone's entitled to their private opinion as well, so go ahead.
Sir, I take your comments very seriously, and I can assure you that in my role, at no time would I take a petition one way or against on an issue that is, the public has the right to choose either way. So what I say to all of our employees is when one of our representatives comes to our community, I absolutely encourage everyone to attend and hear and voice your opinions. I would at no time, and did not and have not, said anything about any specific issue. That certainly the one that you spoke about became a very volatile issue the other night. And I thought it was certainly everyone's right to talk about it.
Right.
And I would not express my opinion or encourage our employees in any time, one way or another. Absolutely would not do that. So unfortunately, whomever thought they heard me say that, I would not have said that. I did not say it. So I would encourage people to go and speak to their elected officials. Absolutely. I think that's our American right, and it's our duty.
Right.
But in terms of encouraging people to speak up against or for something, what I would only say is speak your opinions. Do it in a polite fashion, but at no time would I advocate our employees or encourage them to take a set position.
Yeah. Like I said, it's hearsay. I don't have recordings or anything like that. But I think you realize as a CEO that you have a lot of influence over individuals that work for you. And I was in a supervisory position, and that's what you do. You know, number one, you know, we see that a lot in the news where someone says, hey, you know, I'm your boss and I want you to do this. And they say, if I told them that, they say, well, Orlando, you know, you can go home. But when a person has control over their employment and career advancement, et cetera, it's a whole different situation. But I thank you very
that
much
to
for
me is
your
abuse
point.
of power, and I'm not interested in that ever. And I encourage all of our managers, at no time do you do that.
You know,
We don't
I'll
tolerate
vouch
it.
for Charlie on a different subject when we had that tax vote on whether taxing health care or not.
Measure 101.
Measure 101, he worked very carefully not to take a side on that, try to explain both sides.
Right.
And,
No, I was at a hearing where he was at, or
Yeah.
at a town hall meeting with Senator White. Yeah.
Mhm.
And he, you know, they asked him specifically, Senator White asked him, what's your position on the Obama plan, you know? And he said basically, he answered, hey, you know, this is how the hospital benefits from this, and that's what I can tell you. There are some benefits, and I don't know if I'm right or not, but I thought that's what I heard.
That's what I said.
Anyway,
I didn't say good or bad, I
Right.
said these are the facts.
These are the facts.
And I tried very hard, and I encourage our leadership team and all of our managers to take the same position, explain the facts. You have a right to have your opinion,
Right,
but you don't have a right to, on hospital time,
right,
to try and persuade people to your opinion.
yeah.
You can do that on your own time, whatever you want.
Right.
That's,
And like I said, you know, this person, I don't know who it was or who it is or whatever, they sent this note out, and for some reason they got this impression. You
I'm
know,
sorry.
I don't, you know, like I said, I can't speak to them because they didn't give me a name or anything. But I appreciate your response. And thank you very much for your time. Thank you.
You bet.
Thank you.
for coming in.
Yep.
I think your poster idea is a good one.
it's an excellent. Those posters, by the way, have been a little bit controversial. Not everybody likes them.
They're not pretty.
They are not pretty.
They're eye-catching, that's for sure. If you want to read them, I mean, it's gory.
It's a read though, when you're sitting there waiting for a laugh.
Yeah.
Yeah, that's for sure.
I mean,
Thank
really,
you.
I've read them all multiple times.
Good night, thank you for coming.
Yeah.
Okay, the consent agenda, has everybody had a chance to read the minutes and see the thank you letters and
I move approval of the consent agenda.
I'll second that.
they've been moved and seconded to approve the consent agenda as presented? All those in favor?
Aye.
Opposing? Hearing none, passes unanimously. Okay, Cheryl, you're up. The financial reports, you're on the hot seat.
Okay. February was kind of a slow month for us. The total hospital down 286 from 349 the prior month. Year to date, we're at 2681. Last year at this time, we were 3,042. The big differences are in the emergency patients. We're at 2,062, down 428, but look, they all went down and went to the clinic. They're up by 432, so that's all right. Surgical patients is the other big change. We're up 57. Not a surprise, given more Bradbury and Dr. Sprinsky, and so that's all good news. The ancillaries continue to be very strong. They also slowed down over month, but that's kind of to be expected. February is also a short month, and those couple of days do kind of have an impact on us. So year over year, we're still going like gangbusters over here with radiology up 17%, rehab still up 13%. Home health is having a big year, not sure why, but so good news there. Our gross monthly charges, of course, because we went, we had a slow month, our gross charges were down to $2.5 million. So that was our worst month so far this year, and it's about $400,000 below our average this year.
That's the February one, right? Correct?
Yeah. Well, this is $2.5 million, and our average is 2.9, so we're well below our average for the year. February was.
Yeah, but it's a short one.
Yeah, it's a short month. All right, so then in our collections on AR, this is a harder screen, but this is February. Our collections were 1.3 million. We've had a month like that in each of our past 3 years. So I guess this is the one for this month. Very, very low, 500 below average, 500,000 below average. But this is what happened in March, which is closed. So this is the one bit of information I really can report from March. It's cash collection, so it doesn't rely on me closing the books to know what it is. So that number is $2.7 million, which is $850,000 above average. So that's kind of great.
It's actually our highest month that we've collected.
Yeah, it's an all-time, that's right. Record
So
high.
didn't you interrupt collecting too?
Yes.
It's an all-time high. It's an all-time high.
Yeah, yeah, never had bigger. And I guess, I'm not expecting to see that with revenue for March. I mean, it wasn't a super busy month in the hospital, so collections were good. Our days in AR are, for March, we're right here, and that is 89. February, thank you, that's February, it was at 89. Now between then and now, so it dropped almost 10 days to 80 as of March 30th. 9 days as of March 30th, and it's down another day as of the 5th of April. So Lisa is going to talk about days, or about AR in a minute when I'm done with this piece, because she's got a lot of new information. Days cash on hand is at 89, so it's a day below where we really should be. I do have $1 million that we can borrow on the bond, which we're going to get done in April, and then March's cash collections will help significantly. So that's going to bounce back pretty quick too. Okay.
We received the Medicare adjustment, right?
Yeah. Our slow month here, so our net revenue was $2 million. Our expenses were $2.3 million. We were below in expenses, below in revenue, and our net loss for the month is $82,000. It was $93,000 worse than budget. However, our year-to-date net gain is $863,000, which is $772,000 ahead of budget.
That includes that gift of $350 that's reserved for.
Yes, it does.
Okay.
Yep, it
So if you take that away,
Right.
you're still at about $500,000.
Okay, our balance sheet, I'm not sure if any of you actually noticed, but I'm gonna point it out because it's an anomaly. Of course, our cash went way down. Month over month, the cash was down $1.7 million, which is bad. But our liabilities also went down by almost $900,000, so that accounts for about half of that decline. The other big change you see is right here in receivables, going down by $1 million. Now, this has nothing to do with patient receivables. That's all up here on this line, and it went up month to month. But down here is receivables mainly from Goose Lake and Lakeview Gardens. And so what happened here is we did the auditor's adjusting journal entry, which doesn't affect, it affects the last month of the closing year. So it goes backwards. Yeah, we did drop that receivable because we entered an allowance for bad debt. We said we might not get this money, and I hope you'll remember that. But anyway, that's the majority of that change right there. So next month, not so much big changes. All right, so now Lisa has some good news for business office.
And you guys know how I love speaking publicly.
Yeah.
So I really just kind of wanted to give you an overview of my first year here, which has been, quite exciting. We've had a lot of changes. I failed to get my AR days down at the hospital, and I'm beating myself up over that, but I did accomplish quite a lot during this first year. And as you know, as patients, one of the first things I tackled was actually in the clinic, because there were some issues there. And we actually, a year ago, our days were at over 300, and as of today, they're at 90. So we've really done well with that.
That's the remote.
So just isolate the clinic AR.
Just the clinic AR, just the clinic AR. And we're getting our bills out timely now. You may have noticed you're getting regular monthly statements now. You can trust that the balances are correct because we have a process in place to make sure that we audit all the accounts before statements go out, make sure all the adjustments are posted properly. And if there's any refunds, we move those and things, so we make sure that the statements are clean when you get them, and they're coming every month. We've got them on a cycle. I'm sure you noticed for a while you weren't getting them at all. And hopefully you've noticed your EOBs are on current accounts. So we really worked hard to get that cleaned up. I mean, I know it's not as much money as the hospital does, but I think it was really important to focus on, just because it was pretty broken, I think, from the conversion over to eClinical. So we really got that straightened out. I've got a great staff now. We had a lot of transitioning. We lost a couple of people, but we weren't too sad about that. 2 of them. Anyway, and so we ended up having people stolen from my best people, of course, stolen from my department to other departments. And so I learned, oh, this is how we play the game. So I stole a couple of good people from other departments so we could build up our team. So
We did, yeah.
yes, I kind of scope out the good ones and would corner them in the hall and say, hey, do you have a minute? And so yeah, I stole a few people. And I really changed the training process of what we do with the newbies. Because I really feel like you need to have a strong foundation, and I don't think we necessarily had that from previous new employees just because of the way we trained them, because they basically came in and got a very little bit of training and were handed their whole group of accounts. It's like, okay, so here you go, see ya. So the way I'm doing it now is, regardless of what area you're going to work in, if you're going to be a biller or a admitter or patient services, whatever, the first thing I'm doing is having them train in admitting, because that way they can learn the system from the very beginning and see why things are done and how the workflow goes. And then once they get that, we move them back into their position, their billing position, and instead of giving them all their accounts at once, we'll give them a group of accounts, train them on those, make sure they completely understand them, they're on board with those. Then we'll add another set of accounts and do the same thing until they finally have their full workload. So their learning curve takes a little bit longer, but it's complete, so that they're able to do their job better than they would have been had they just kind of been thrown in. When I first started, one of the things that I heard from new staff was the words sink or swim were actually said during the training process. So we fixed that, and I really feel like the team is working really well together. We used to have everyone's scattered. So it would often be, the culture was, us and them, and so it was like different teams and different
You mean
departments.
scattered?
Scattered,
Physically
physically
location.
scattered, so we weren't all together. So now that we're together, when we did the move, I actually was careful of who I paired together, who I thought personalities would work together and jobs would work together, and kind of made sure that it wasn't so segregated between their, clinic and hospital and wellness. So I think the team is really working well together. I think we built a good foundation. I think the culture has changed and they're much more positive, don't you think? So
Very much so.
everyone's getting along really well, they're working together, they're helping each other where they need help, and I'm really proud of them. I think they're doing really well. So our next big focus is AR days for the hospital. There were some struggles. I feel like this is probably, of all the jobs I've had, my biggest learning curve because we have so many systems. So since I've been here, I've learned DME Works for the DME billing, CPSI, Clinical Works. I'm trying to get a handle of Credible now for the wellness billing, and also point-click care for the nursing home. So it's been kind of a lot. And I was finding too with CPSI, their reporting is kind of lacking. It's really difficult. You can't manipulate it. There's only just a few reports I can run and then just export directly into Excel, and it works properly so I can sort it. So I actually spend more time than I should just figuring out what work I need to push out to my staff. And so I've been running the over 120-day report and breaking it up by whoever works it. And so I give them those once a month. And so the first time I did that, most of the girls came to me with their sheet because there was some old big stuff and they're like, I've never seen this person ever in my work queue. And so there's some black holes where they're not popping up and they're not seeing them.
That's from CPSI, unable to generate the report that you need.
Well, now that I can generate the report that I need, the accounts are on that, but they're not necessarily in the work queues. So when they come in and they're doing their daily work, these people don't pop up saying, hey, I need follow-up or I need to be billed. And so there's some piece that's missing there. And the only way that I'm ever able to find those is to do these monthly reports. And so that's something I'm doing every month. In fact, I was working on that before I came in here. And that's really helpful. And I think that's really where our big bump in payments came out, because I started doing that 2 months ago. So, when they worked those, that's when you see February was low, but then March just really went high. And even the first 3 days worth of payments we've gotten this month are really good. So I think that's going to help.
She's running those reports, but they require quite a bit of
manual manipulation.
Right, so is there an easier way or teasing the information out without having to do it manually?
Anything's possible if you're willing to pay for it, right?
Oh, okay.
So, see this handout? Yeah.
So we've seen a demo of the product at True Ridge called RICAN, and I think I saw the demo within my first few weeks I was here.
And I gave you some examples of some reports that
Right.
I gave you 2 example packs. I didn't print it 5 times because it's too hard to read and I couldn't get a better copy. I'm sorry. So I just gave you a couple that you can just go through. Sorry.
Yeah, and it's a pretty slick product. I liked it when I saw it, but I'm not a fan of add-ons where the company gives you something that doesn't work right, but then they say, for an extra bit of money, we'll give you something to make it work right. And so what I really tried to do is, instead of spending extra money to have an add-on that gets the information, I wanted to see if there was any way that we could actually get the information before we had to pay extra. So I really kind of can't. So I think we have to go that direction. But we've done some additional training. We had eClinical Works. Well, sorry, we had Evident out here for a week doing training. They trained me and some of my new staff, and I also had all of my existing billers come in so that we could make sure that we knew everything that was available to us and making sure we were using it properly. And then just this week, well, it was yesterday, We had a webinar with somebody else from Evident who's doing, for the entire facility, they're going through and making sure that we are using the system as it's intended. And so I had the billing team come in and we sat on the webinar with the guy, and so he said, okay, when you come in the morning, where do you go? What report do you run? How do you do this? How do you do that? And verify that we are actually using the system as intended, which is a good thing, but also a bad thing, because if we're using the system as intended and we're not getting the results we need, that's kind of a concern. So before the trainer left, and Devin, who's our account rep, was here, and he's the one who'd done the demos for RICAM, and I said, this is how the training went, and here's my issue. We are struggling to get AR days down, and this is what we've done, this isn't working, how can we get there? And so he said, we talked about RICAM again, and so we just decided that's what we're gonna have to do. So that really should improve our collections. He said that he has some clients that were over 100 days in AR, and they got them down to 45 to 50 just using the system, because it pulls the information that you need a lot easier. So,
Then that would be worth it.
yes. So they're going to move pretty quickly. Our first kickoff call is next Friday, and then they're going to start. I think it's not going to go as fast as I'd like for the implementation, but I'm talking to them about speeding up the process. But what they're doing is there's a few modules, so what they do is they have to do them in order. So they install the first module, and then once that's all done, then they'll do the next one and the next one. And I think the speed of the implementation is really going to depend on how well it goes. So if they come in and it goes smoothly, it could go faster than the schedule, and they can move to the next one quicker. So it's really going to be down to how the interface works and how everything goes with IT. But I'm really excited about it. I think it's going to make a big difference. What else?
Me too.
Oh, excellent. You weren't that nervous, you did just fine.
Well, I think I was just a little nervous because I'm my worst critic, and so the fact that I haven't met that one goal really weighs heavy on me, because I just feel like, this was the biggest, most important thing. But I probably could have reached it, but not without fixing the clinic. And even though the clinic is less dollars, it was just, I hate to say this, but it was just kind of really bad. And I just couldn't let it sit. I really just felt like we can fix this. And so I really just focused on fixing that. And I think we're not 100% there, because I'd like to get our days down to 60 is my next goal. And then my next goal is going to be 45. So we were at 80 days the month before and 90 days this month. And 90 days was my first goal for them. So we're making progress.
So you just said that backwards.
No, we were
You were
90.
90 and then you were 80.
No, not for them. We were 80 last month for some reason.
You went up 10 days?
We went up 10 days.
Oh, okay. All right.
Oh, I think it was due to some refunds, because we had some old refunds out there which we cleaned up. Which
Okay.
affected adversely.
Questions?
Any
Well,
questions?
just a comment, I'm disappointed that CPSI doesn't do this for us. I always thought they did.
Oh, yeah. Well, I agree, because I've been very resistant to buy extra software. But when I started looking around at other people, other critical access hospitals that are like us, I realized that everybody does something. And
As I understand it, even Epic requires
yeah,
additional modules that are
yeah.
additional costs. I
And this
thought
software will work with Epic or Cerner or eClinical or anything. This isn't just for Evident.
Okay.
So if we
It's a
change, we'll
scrubbing
go with
tool.
it.
It's a scrubbing
And reporting.
and reporting.
Yeah.
Okay. Thank you.
Okay.
If you wanted to duck out, like you probably could.
Oh, only if you're going to talk about me behind my back.
You might want to stay for the
Okay.
What are we gonna say?
Cheryl, you're back on.
Okay, Goose Lake Medical, starting with Lakeview Gardens. Short month, this is really very close to 24 patients, so full, very close to full for the month of February, 668 days. But it was a short month, so our revenue was down just a tad to 197, below the average of 205. there's our 197, still paying big bucks for contract labor. And also rent, you see the extra 40,000 or so in expense for the rent that they're paying now. The loss for the month was 99,000. The loss for the year is 561.
That seemed to be, I was trying to look that over, it seemed to be,
Oh, sorry.
it's costing us more compared to the old facility by quite a bit.
Well, yes, I mean, you got a different, it's a totally different ballgame for sure.
But is a lot of that the contract costs, or is it
In contract costs, what do you mean?
contract labor?
Labor.
Well, yeah, I mean, so far this year, we've paid, this year we've spent 416 in contract labor. Last year, we only spent 176,000. I mean,
Yeah.
that's big right there. And we kind of knew it was coming, you know, we continue to do classes and hire people and look for people. And, I mean, I think we make some slow progress, but there's no getting around that contract labor. And you'd have to trade it off for regular labor, but I mean, you pay almost 3 times the amount for, I mean, you gotta pay travel, and you gotta pay housing, and you gotta pay a high wage, and it's kind of crazy.
Shouldn't that level out though as we go through the next few months, the next year? Shouldn't that level out?
We can find people.
So we graduated 9 students since January. So we have several different things that we're working on to improve that. So we've got a more robust training program. Secondly, we're about to establish a CNA 2 class. So there's a difference between a CNA 1 and CNA 2. CNA 2 is someone who has proven their skills as a CNA. And there's a series of tests and proficiencies that the Oregon Board of Nursing allows, that is included in that testing. When they finish that skills test and essentially get that certification, we can pay more. So what that will do is 2 things. It'll have a ability to prove that our staff are better trained, increase wages for the CNAs because of that staging, and gives them more of a process for getting to a next level. So that's really a positive thing. Turns out in lots of the urban hospitals, they don't even hire CNA ones. They all require proof to be a CNA. So it's also improving our qualifications and the level of quality of service that we're delivering.
Do they have to have some service before they can go for CNA too?
Yes. They have to have worked, and then now they can prove their proficiency after a certain level.
So in an urban environment, what do they do for?
They may work in a nursing home first,
Okay.
and then take the CNA training for 2, get certified, then get hired at a hospital.
And soon, we'll start accepting people for assisted living, so the contribution margin for that should help. There won't be any additional allocated expense for assisted living?
No, I mean,
Okay.
I
So
suppose
right now,
like utilities will get more
Lakeview Gardens is
expensive.
carrying the entire allocated expense, so we can look at a contribution
yeah.
margin.
And a lot of those people have been in training for the ALF, so you have a lot of staff, extra staff that's been in training. Then when the ALF opens, they'll go to work. So you got more staff than you're gonna, than you should have, because we're trying to get them all
So
trained.
will that be
ready to go.
sometime this month when we start receiving, or is it next month?
I wasn't going to talk about it later, I'll talk about it now. Our plan is that May 4 is the date that we will switch how we're handling meetings. If all goes well, they'll do the first testing. If all goes well, it'll be completely done by May. the next week, it's May 12th, I believe.
What will be all done by then, Chuck?
So in order to open up the assisted living, with all the people trained, we're taking several of the people that have been working in the long-term care and moving them to the assisted living. So we have that cross-training. To do that, we're taking the meals and bringing them back to the hospital. So the main process of meals are going to be cooked here and brought over to the government.
So we still have not moved anyone into assisted living?
We have not. I'll have a little bit more to talk about that when we get to our construction. There's a fair amount of things going on there. But that's our situation.
But you will tell us what's happening here
Yes,
later?
would you like me to do that now?
Oh, I don't care when we do it, I just would like to hear it.
When you say meals, Charlie, you talking about breakfast too, or do you cook breakfast locally?
It will be lunch and dinner. The breakfast, lunch, and dinner will be cooked for the assisted living, in the assisted living facility. With long-term care, will be cooked here and brought to the facility, each of the cottages. They've got a very organized process for a plan to make sure that happens. There's been a lot of training to make sure that it works properly. This is one of the big things that we've found over time is we can make most meals patients are happy, but we struggle with being consistently good. We can do a better job of being consistent when we have people in the kitchen in the hospital doing the cooking. And there's too many variables in the cottages for that consistency.
So when you say assisted living's gonna cook your meals there? Okay, so you're not overloading our kitchen.
Cheryl, you're back on.
Moving along. Looks like medical revenue was down a bit, expenses were down a lot because we didn't have to pay any locums. We lost $5,000. We're getting ready for Dr. Foster to start going down. We've got Roseanne going down, and that practice is building. And between Jamie and Nam doing projects and working on efficiency, we actually are starting to see a little bit better productivity out of Tony, so that's kind of exciting. And then the other thing, of course, is Katie Jo Rabel has been harassing the state of California almost daily to continue the progress of the license transfer. So if you're interested in seeing some of that conversation, she sent us a whole lot of emails of what she's doing and how she's doing it, responses she's getting, and I don't know what to say except she's being a real big major pain in their butt. I think she's got their attention. Yeah. And medical supply, their revenue was down a bit this month, just like it will be, and so their net profit was $1,230. So, it's good that it continues to be a positive bottom line. Year to date, or prior year, or prior month was quite a bit bigger, and year to date we're at 30,000. Not really bad at all.
Okay, are you,
Pardon me?
any questions for Cheryl? Okay, we'll move to the expenditure updates. Surplus items,
We sent out a list of, I believe you got a copy, of the items that we'd like to have declared as surplus in preparation for having a garage sale. We have to do that because we need to allow all residents of the county.
one question on the timing of the garage sale. When does Lions have their auction?
First weekend of May.
I wouldn't want to step on their auction.
I want to say Tina mentioned the second or third week of May is what.
Okay, sometime after the Lions
Yeah,
auction. Okay.
yeah.
We had a
'cause-
date of May 12th, but if we have to move it further along.
Yeah, I just don't want to step on their,
You don't keep
right on their parade. No. Maybe as a Rotarian, maybe, but, you know.
I would move that we authorize the surplus sale.
Okay.
I'll second that.
Been moved and seconded that we authorize the surplus items as presented for sale. All those in favor?
Aye.
Passes unanimously.
I
Okay.
wanted to inform you of two items that we had to purchase that were not on the capital list, but we still had to do. One is putting in a loading dock ramp, and that's for the $9,900. We've been talking about that, but it's become more and more of an issue, especially now that we have more employees working in the business office in this location. Going up down those steps is unsafe during the winter, so this would put it on a handrail and make it safer for employees.
So it's going to be a heated ramp, maybe?
No. It is a wooden.
Okay.
Second item, we did not budget, we weren't sure that we were going to need it. It's the paging system for the doctors. And the system died, we had to replace it. We struggled with finding a good system. You'd think everybody carries a cell phone, but that would be the easy way. Well, there are some places that the cell phone doesn't work. And you can't expect every physician to carry a pager all the time, or a cell phone all the time. Not all do, or certain circumstances, but they do. They're comfortable carrying a certain pager. And these pagers are secure, so when the physician is notified, sometimes they won't say they won't breach HIPAA violations, but they may say some things that are very patient-specific. And you need to protect that, so we needed to have a system that would accomplish that. We looked at a bunch of different things. This works better, so we had to make that expenditure. That was $27,000. I sent you out all these.
Is that run off the Black Cat?
I believe so. Because we have some, well, Lisa Caniel is on the other side, and not everything gets there. So we had to find, so it isn't just black, I think it's also grizzly. And they had to make sure that these, we could cover not only to the north, but also to the south. So if any of the practitioners are within reasonable distance. So that's the reason for that.
And the EMT people don't have that, right?
We have a completely different system. So that's what I had to do.
Okay. Thank you, Charlie.
Okay.
Next item.
So
Mr.
let's-
Marchand.
Okay. Actually, rather than talk about the clinic first, let's talk about Lakeview Gardens.
Okay.
First off, we, as you know, we're under the 1-year warranty time period. And there have been some problems. One of the things that we found, of course, was the blinking lights. It took us 4 months to get the right, everyone agreed to, and finally got that addressed. Those lights all got replaced, and the manufacturer had to bring out extra of these, they're like a thermostat, or not a thermostat, it's a regulator, so in case it doesn't work. So far it's working, so that's a positive. We've had some issues with heating and air conditioning. For some reason, the regulation between what the floor temperature is and the ambient temperature in the room was working great when it was the air conditioning, but it was crossing over itself with geothermal in the floor. So they spent a bunch of time, the engineers and architects, figuring out what was causing it. Not sure they have actually come to a final conclusion, but they're working on it. Another big issue, this is a very big issue. Turns out, when they grouted all the bathrooms, they used a product that had the sealer embedded in the ground. It didn't work. all the grout in all the bathrooms has to be removed and re-grouted and resealed. So, if you ask, how soon are we going to be able to be in the assisted living? What the manufacturer and the contractor are going to do is, starting off with the assisted living, they're going to remove all the grout in all the bathrooms. Then they're going to put in new grout, seal it, make sure that they have the odor control and all the other factors that go with it. Then they're going to start on each of the gardens. They originally wanted us to move all the residents from one cottage to another. We said, unquestionably, that is unacceptable. So they're going to have to do one room at a time. And they're beginning that process, I believe they're starting next week in the assisted living. But you can imagine it would be roughly a 4-day event for each bathroom. So clean it, dry it, put it in the new grout, dry it, seal it.
So what are we going to do with the resident while their restroom is being?
We are going to have one room that is not occupied. Okay. And move the resident into that room, and the next one, and the next one. It's not at all a happy situation, but it is within the warranty period, so they have insurance to cover it.
Have we notified the residents and their families that this is going to be coming up?
We have had family meetings. First we told them what we're planning. Now we're having the Adroit's representative and manufacturers and people available to answer questions to the family members. And we will do all we can to assuage the family of concerns and whatever else we need to. I'm just glad this is found during the warranty period. So, not exactly going the way we had hoped. We wouldn't have any problems with it. I'm glad it's being addressed. So, we will be changing the meal process. That will be starting in May. We believe we have all people hired. We're in the process of going all through the training. And we're on track. So, we've made it very clear that we are going to open this assisted living in my lifetime.
Are you sure?
I am absolutely confident that we have a solution for all of this. In terms of the clinics, there are a lot of things that are happening, going on with the clinic remodel. So right now, as of this week, our plan, it's a staged process for when we can.
Number 1 is open.
Well, all I need is the pointer.
It's right there.
Go ahead, pointer. Oh. One-arm band, it doesn't always make me think like a one-arm band.
So there's the phase 1.
You made it.
For number 2.
I can never make a calendar. Okay, so we have 3 inspections that have to occur. Number 1, it has to be inspected by the county for us to get certificate of occupancy. That was originally, it is now scheduled for the week of the 13th. Once that is done,
Which month?
this, so the week after that.
April 13th? Right?
2018.
Okay. So the next component of that is, it has to be approved by the fire marshal. So in order for the fire marshal to approve it, it has to make sure that every area will be sprinkled. Once the fire marshal and the certificate of occupancy is granted, and the construction company is not sure if they find anything that has to be done, they have about a week to get all those things fixed, whatever that might be. When that occurs, then we have Department of Health and Services, DHS, will come here, and they're scheduled right now for the 19th. That's as soon as they could be here to do the inspection. Okay? Once that occurred, what will probably happen, so just to put everybody into perspective, this is the specialty clinic, this is the hallway that leads to, this is where Lake Health Clinic is, this is Dr. Graham's clinic here, this is the sleep lab here, and the pulmonary rehab is here. So the new construction, which is the central check-in space here, these two spaces are what will be inspected by each of the inspectors. What we'll do is we have the right, once we get occupancy, we will take one of these rooms and set it up like an exam room should. We'll bring take one of the rooms here and move it in and set it up as an exam room. When the DHS inspector comes, they will measure to make sure all of the access points, all of the restrictions and requirements are met. Once that has been approved, then we can actually move it in as a clinic. The expectation is on the 19th, we get that inspection. We don't think we'll have any problems. The 20th is the Friday, it's a Thursday, Friday. That weekend, what will happen is this hallway here, which happens to be Dr. Gallagher's office, and this hallway here, which happens to be Dr. Hussey's office, those walls, they had windows in them, they're now plywood. That will be opened up, and everything that's in here will be moved into here. So our crews are ready to move everything in, set it up as the clinic should be set. It's not where its final set will be. If you recall, these rooms along the back are predominantly going to be for mental health services. So they'll be set up to work. It's not perfect, but it's during the construction period. What will also have to happen is this is a tunnel. So a joint will build a wall here, cutting out through these two exam rooms, a plywood wall that will allow patients to be wide enough that people will walk in this entrance, check in here, and then be brought here along this way and brought in to see their doctors. Okay? That's phase one of the tunnel process. Phase two, and the reason, and I'll explain why they have to do phase two. Here's phase two. What will happen is we will lose the use of this corridor. The reason for that is we've got to change the configuration of this wall. All of those metal fire gates have to be removed. They have to do all sorts of plumbing and work above in this hallway. You can't let anybody be in there. So to accomplish that, once this path has been organized and we've settled down so we don't have any messes with it, it may be a week, maybe 2 weeks. And what they will do is cut out through these, this is where the entrance is right now. This is where some of the business office functions are. Their office is right in here. And they will build another tunnel. It will go through the wall, out into the outside, and come down here. And there's the door right here. They'll actually move the door further down, so it'll be right next to the hospital side. And it'll be an outside covered walkway with a railing. That allows patients to go from Dr. Graham's office or from the clinic and still be able to use not that corridor, but a corridor. If we didn't do that, everyone would have to walk outside. And I didn't feel that was in our patient's best interest. So that's what is going to be the second component of this.
About how long would that temporary access be?
They think it'll take about a month to 2 months. I say month, they say, well, we maybe need 2 months. So I'm guessing it'll probably be 2 months, that they'll need to redo, to use that road.
At least it'll be here in the spring and summer.
That's correct. So this will be happening roughly June, July. Maybe a little hot on the outside, but I don't know how else we can do it. So we will have posters of this displayed throughout both the hospital and the clinics as of next week. So people are beginning to get aware. We'll have as much information on this as we can. Have it at the front entrance of the hospital and help people, direct people where to go. So that's quite a bit on that remodeling process. The specialty clinic already has been, they've been removing materials and working on that a lot. So they think, Detroit thinks it will have sped up maybe a month in their overall process. I'm not sure we'll actually be done faster, but we'll see. That's their hope, by moving specialty clinic to the best wing. As that process goes. Any questions?
Who's messing with the,
I don't know, nobody's
But
touching it.
Is Dr. Graham's building, is it sprinkled?
Pardon me?
Is Dr. Graham's building sprinkled?
It is,
Even the hallway?
yes.
Okay.
One of the challenges that they had in the design process was that center component was not. And they had to incorporate that. And we had to change the water, where did we get the water, how big was the water line for feeding the sprinkling system. I mean, there was a lot of complications with it. So, but they think they've got that sorted out. So it is our expectation, unless something doesn't go well with these inspections, that we will be in the new clinic space on April 23rd, open for seeing patients. Okay? As an example of how you never know, a week ago Wednesday, they still had not gotten, it was delayed a week because the flooring was still sitting in CI. On Friday, a week ago, the flooring arrived and the installers were going to work all weekend to get it done, to try and get to be within schedule. So I can't explain why things happen the way they do. That's what we have to work with. Any questions on those issues? I would like to bring up an agreement with CT Design. I think you all have a copy of that. We have two options. Number one, the reason I bring that is because CT Design is, my wife is a landscape architect, and obvious conflict of interest. What Adroit has said is, right now, she is working as a subcontractor to Detroit. They are willing to continue that relationship. They have said that they'll try not to charge their add-on fees. I think it is less expensive if we have a direct contract. You can observe it, anybody can, or the board can oversee that process. But I think it makes it easier to not have the Adroit add-on for their oversight management. They said they've tried not to do that.
The only thing in that contract I didn't see is what our estimated total is going to be.
And not to exceed.
it's not to exceed 10,000
Oh, okay.
per annum.
And it's too hard to add, because what that would do is it would allow for us to continue on finishing up Lakeview Gardens, because it still hasn't been finished. And the space for the clinics. And anything else that we need to look at. There's only reason. I'm happy to listen to whatever the board would recommend.
I move that we accept the CT design contract as stated.
Yeah, we got it in our packet.
I beg your pardon?
We got that in our packet.
Yes, ma'am.
Yeah.
Would you like a copy? I could.
No, I read it, I saw it.
Any other comments?
I'm just a little, yes, I guess I have a comment. I'm a little bit confused about why it's cut, why we have to pay an additional up to $10,000. When I thought we originally had that within the full contract obligation.
In the original contract for Lakeview Gardens, it was a pinnacle fee.
True, it was.
In the clinic remodeling, they had allocated money, but they did not have any designation for anybody to contract. So they don't, we have not done anything for it. So they set aside, they're estimating $45,000, but they're really not sure what, as Adroit said, we kind of had a fudge factor for several items based on not knowing what they're going to find in certain areas. So they sort of guessed on this, guessed on that. And so they roughly estimated $45,000 for any kind of landscape, which would include fees, specifically for the clinic. Okay.
So does this include the clinic as well as what needs to be done over here
Yes.
with the assisted living and long-term care?
Yes. It's both.
It's both.
Yeah. It's to finish up the Lakeview Gardens and to finish for the clinic remodel. And Adroit did not have, and ZCS, which is the architect, said we don't have that as a portion of our design. We didn't build it on the outside.
Okay. Any other comments? I'll go ahead and second to accept the contract as written. All those in favor?
Aye.
Opposed? Hearing none? Motion passes. Thank you. All right. I don't see Dr. Graham here, so medical staff update.
As it turns out, the medical staff did not have any approved changes. So I would suggest that we have that as a placeholder in case we have something.
Okay.
That's-
Did Dr. Foster come on board?
Dr. Foster will be here on May 19th.
April 19th.
April 19th.
Oh, I thought it was April 1st.
It originally started as April 1st. He then moved it to April 12th. And then he asked if he could, no, not 12, 13,
15.
15.
Then you made 19.
And then he asked if he could, for personal reasons, go for a couple more days. And then he starts here working in the emergency room on the 19th, and he's scheduled to see patients in the clinic, and he's already booked up on the 23rd. I'm not sure he's fully booked, but it's pretty booked.
Okay. Board education.
We can get this. One of the things that's happening, thank you. Does the clicker work on that? So, oh, there you go. It worked. Excellent. Okay, so one of the things that's happening with our Oregon Health Plan, the CCO product, is they're now talking about CCO 2.0. And this specifically is mental health, but I don't know if any of you have gotten the notices, or we'll send out another one. Everyone has an opportunity to weigh in on CCO 2.0. And so the state is now beginning this phase 2.0, and they want to have input from everyone that they can get answers from on what do they need to do next for the next 5 years. Governor Brown has made these as principal components of her re-election. Maintain sustainable growth, increase value and pay for performance, focus on social determinants of health and equity, and significantly improve behavioral health system. So there's a lot of talk and a lot of money that is going to be focused more and more on the behavioral health system. Integrated, which is, as you've seen, both in our construction work as well as how we are working to try and bring more mental health services in with our practitioners, our medical practitioners, to integrate and have warm handles. That is a key component for these next 5 years going forward. And we're poised to be able to try and do a better job for our residents of Lake County. Big question is, again, what do we call integration? As has been reminded of me, it's one thing to cohabitate. That doesn't mean you necessarily integrate. Just because a psychiatric practitioner, a therapist is in a clinic, doesn't mean the doctors talk with that therapist. We need to figure out ways to help the doctors and therapists work together. So we are positioning ourselves here in Lake County to do this better and better. But that's going to be a big issue. Last week, Don and I met with representatives of North Lake Health District to talk about using some of their space, renting from them, to put mental health therapists in their clinic so that we have better integration with the Lapine Clinic that's seeing those patients. It's called, oftentimes you may have heard the term used as warm handoff. That's when a physician says, Mr. Smith, I think you have a substance use disorder, or I think your anxiety is an issue. I'd like you to talk to this person. Here's this person, talk to Bob. And they're in the same location. That's a warm handoff. Versus the doctor saying, Mr. Smith, I'd like you to make an appointment with Bob at mental health. Turns out about 25% of the people actually make the appointment, let alone show up. So we have a big break between them. So the more that we can encourage that to happen, it takes some of the stigma away and it makes it easier. It also allows us to help kids who are having problems to get the care that they need. So March 15 was the CCO 2.0 kickoff. These are the agendas that the state is working under, and everyone is encouraged to voice their opinions. These are the steps that the state is looking at with public comments. It's a busy slide, but it really talks about multiple different occurrences when the state will look to, by the end of the summer, start making some changes to their policies. Okay? And 2018, public policy and input, 2019, contract and procurement, and beginning 2020. So that's the plan. Any questions?
I've seen that you gave it to us in the packet. We can go online and do the survey.
Okay. I wasn't sure if we had sent this out, but I thought it would be helpful to not only have you hear it, but people that watch the video of this meeting, chance to see this, and we'll try to make it available on our website and let people know to go and make their comments.
Charlie, did you make any recommendations, or are you making any recommendations?
We're working very hard to do the integration. So our recommendation to other places is how do we work to really help support the patient by supporting the doctor. How do we get resources to the doctor? Because that's funneling those resources. Because when the doctor or the nurse practitioner or PA are seeing that patient and they're identifying some of those problems, we need to give them the tools to say, this is how we deal with it. This is a quick way, and helping the patient then get there. So sometimes it's physical, sometimes it's, I mean, you have to have multiple solutions because not everything works for everybody.
Is CCO involved at all with the colleges as far as training new staff?
Well, the CCO, Eastern Oregon CCO, has put up money to encourage employees to become community health workers. And the Oregon State University Extension College, that's where we sent a lot of our local employees to go and get trained to be a community health worker. So that's one form that they're doing. Our CCO put up a bunch of money to try and encourage residencies to be occurring in smaller hospitals outside of just Portland. I mean, as an example, St. Charles in Bend is allocated one space for a resident. It's a convoluted process of determining a hospital and what kind of training programs they can have. That was established many, many years ago, and is unfair. So there's been movement to try and change that. So both from the first entry-level practitioner positions to the high-end, the top of the food chain residency training programs, it's been involved. That's not true for all CCOs. I don't know what all the CCOs are doing, but not everybody is as aggressive as Eastern Oregon CCO.
Any other comments? Thank you, Charlie. The word has been educated.
Well, I thought it would be helpful.
Kind of. You're going to have to, it's a continuing process. Employee recognition.
Well, we've had some marvelous things that people are doing. One that has been exceptional. When we took over mental health service, not only did we find there was some things that had been left undone for a long time, we found some chaos. And one of them, as Lisa talked about, was the credible software. We brought it up to current state, and then with our informatics team, we have had them focus, each one of them focuses on different software. As you see, we have 5 different operating systems that are used within our organization. One of our employees has become sort of the expert on credible. That's that very safe, protected software used in mental health services. And this month, this employee went to the national conference and made a presentation on the results of the efforts that they've made here on how to take it from a position that was in confusion to where it's organized. That employee is Amy Riches. She is our employee of the month. Not only did she give a good presentation showing how much they have made in improving that software, as she pointed out in her presentation, when we took it on, they had an accounts receivable of $1.5 million that was due the county. Well, it was a billing issue. It wasn't actual credit. Brought it current, gotten it organized. But you know, when you make presentations at conferences, they rank how good of a presentation it was. She got 4.5 out of 5 stars. So did an excellent job representing Lake Health District in a national conference. Amy Riches.
Good. Next item is the CEO report.
One of the things I'd like to do first before I jump into that is ask Patty, who is here, did you want to say anything about the adverse event reporting? Rather than talk about, she has something else to talk about in the executive session, that which you presented yesterday at the department head meeting?
Well, it's just a policy that we've had for a little bit, and it's just got rolled out a little bit more yesterday. We've been doing electronic and paper copies in our policy process. We've been trying to transition over to electronic. So I had it in the electronic, thinking we were all going to go electronic very soon. So some of the staff hadn't seen this adverse events reporting policy, although they've been following it for quite some time. We have an electronic system that we use for adverse events. So anything that comes or happens in an apartment, inside, outside with visitors, non-patient events, of course the vast majority are patient events, and also employee events, which really just has to do with injuries. Employee injuries are all put into this electronic system, and it works very nicely for us. There are certain events that have to be reported to the Patient Safety Commission. In many states, it's required that if you have they call it adverse events, but if it's a, excuse me, a certain level of a serious event, then it's often required that you will report that to the state. California, for instance, was an early adopter of that. And most of the states have taken that up. Oregon has adopted the stance of, well, we'll get as many healthcare facilities to join in, and it's voluntary. But once you volunteer your organization, you are required to make a report to them, and a report requires certain things. You have to do an investigation, of course. You have to do a root cause analysis. You have to, with a multidisciplinary team, work out some solutions to that. We have been doing it for some time in the hospital. The nursing home has been doing it for a number of years now also. And so that was discussed just a little bit yesterday. As I said, though, they're already doing it. Well, and there were a couple of other attachments that we gave them. So it's, you know, if you have any questions about whether or not we report our events, we absolutely do. And do we report them internally? We do. If they, a number of eyes can see them internally, it's a much more efficient system than when it was just paper. Paper, it would, you know, sit in somebody's office for a while, and then there's just this one, and it might work its way through the system and get to me eventually. And now I am notified as a risk manager right away. I get all of them. If I see that someone isn't notified that should be, there are some that Charlie, I think, needs to, he doesn't see all of them. He doesn't need to. But if there's something that I think this is something he should be aware of, easy peasy for me to shoot it over to him too. So it's greatly enhanced our ability to communicate on these and to get right on them. Do we continue to under-report? You know, statistics say that we do. And you know, that it's one of those things you have to be careful what you ask for, because I can spend literally all of my time doing incident report interviews, investigations, and I don't have it. But it's good news, it's been a good curse. So that's, I don't know what exactly you want me to talk about.
I think we sent out to you a list of the information. But I wanted you to get a sense of how robust the process for looking and finding problems and addressing them. So that was really what we're talking about. So a couple things that have been going on in the last month. We have a sleep lab survey that's beginning April 14th. You recall we became certified as a national sleep lab facility. Now they're coming out for their survey. Dr. Barfield, who is our medical director, will be here during the survey and he'll be coming here from Portland. He's an expert in the sleep lab process, and he will be providing some continuing education for our practitioners while he's here, because we're going to make good use of his time. The Caravan ACO, remember the organization that we joined effective January 1, looking at our seniors. We're in with a hospital in Guam, a hospital in, a couple hospitals in Washington, North Dakota, Colorado, Idaho. So together we get around 5,000 lives. We haven't quite gotten all the information. We had our first meeting a couple of weeks ago, and so we should start in this month seeing the data. We use a software program called Lightbeam, another massaging data that will give us a great deal of information about Medicare recipients. So the board had its first structural meeting, and I was elected the chair of the board of that ACO. So fortunately, I wouldn't have to, these are all electronic meetings, telephone meetings, so we don't have to go. But we'll be going forward on that. Our infusion biotherapy room has now moved from being in one of the rooms in the hospital to being on the west wing. That relocation has worked very well. And actually we haven't had, to my knowledge, any hiccups with people going for the specialty clinic. People have been able to find their way there. We haven't had any complaints or problems with that. Another component of the West Wing is that we added our DEXA scanner, which is the bone density testing, and we are exceeding our expectations in terms of the volume of patients. So that means it's being used as we had hoped. Another one of our employees has been to a training that's really an exciting thing. We made some changes in our housekeeping, or soon to be named, renamed, environmental services department. And Angeline Jesse went to a training program, and she is now what's called a CHEST certified qualified person that can get all of our environmental services or housekeepers certified as a CHEST, and that stands an acronym that I can never remember, but it's a certification in environmental services. We'll be doing, it'll improve the cleaning that we do and ensuring that we are as germ-free as possible. To top that, we also have a new ultraviolet system that we are now using. It is a standard of care in all large hospitals. It is, in large hospitals, it's brought into every room where there was a known patient with infection. And these ultraviolet light shining, they position it multiple places in the room. It eviscerates all the germs, documented to have done. We are using this now every time we do an orthopedic case. Every time we have a patient that has a known infection of any kind, greatly reducing, even though we have not had any infections of any kind yet. But with this, we hope to keep that continuing. But it is the standard of care in most other large hospitals. So that's a very exciting thing. We're now rolling out and doing, so we'll be doing it in both patient rooms as well as in the operating theaters. Good thing to be doing. Meaningful use, another exciting thing that has been going on. You've been hearing us talking about meaningful use since it got instituted when the monies from the federal government started in 2010, when we got our computer system. For 2018, we had to prove that we met the metrics any 3 months. We significantly met it the first 3 months of 2018, and we have attested. So we have met the requirements. We will now start on meaningful use version 3, or 2018 18 that goes into effect 2019, but there's a lot of work to do to get ready for this. So we now have 9 months to be prepared for that. That's pretty exciting for us to get it done right away. That's due large in part to the hard work of our nurses, but also to Diana Trechter and, of course, helping our practitioners, because they're often the ones that are doing the clicking and the parts that not everybody likes. One of the things, when we talked about the North Lake Health District meeting, that looks really positive. So we'll be moving, and we'll have more to talk about with that. Carly or Teresa is not here tonight to give you an update on all the things that nursing is working on, because she and Carly Alves are in Klamath Falls. They were in an orientation this evening, because tomorrow they are involved in the selection of next year's RNs. And so that's all part of Klamath Community College. At the same time, they're meeting this evening, Carly and Teresa, with the head of the Oregon campus located Oregon Health Sciences University School of Nursing. So the director and the director of the program here in Klamath Falls, and one of the deans from Portland came down to meet with us and talk about maybe we could have a better working relationship with that school.
Did they come to Lakeview?
They did. And one thing that I think was very, very positive, when we had talked to them years ago, they said, yes, we get to it when we get to it. They had a different view this time. Especially when apparently some of the students are saying they might like to do their rotations here, and they're much more interested. So OHSU's School of Nursing campus in Oregon Tech, they're absolutely much more interested. So we have a lot of things happening. Our relationship with Klamath Community College. We are going to be having students doing their rotation here for their clinicals. We are working on having them do their capstone component of their nursing school. That's a really big deal to have that done here in Lake County.
What is that?
So capstone is the last project that the students do before they graduate. And it's a kind of a special project, as I understand it. Teresa will be able to tell you much more about it. But they're working on making sure all the criteria, all the training requirements are met before they can actually agree to it. So a year ago we were struggling with our involvement. We're certainly very involved, and they're here at this level. So that's a positive. That's all I have for right now.
Okay.
Any questions?
Any questions, comments? Okay.
That's encouraging, that involvement with KCC and Carly and Teresa involved with that. That's great news.
Maybe I didn't say clear enough. Not only are we working on the RN students, but what Melinda Utley is doing with our CNA program, that's really making good strides. And so it's a two-tiered program. And we're talking with Klamath Community College about having a medical assistant training program, so that we were able to get students from our high school that enrolled, and they could become medical assistants. So we have multiple tracks for whether you're a CNA or a medical assistant. A lot of great opportunities. And that helps us with turnover that we have, or people moving on. And it's all good for our residents. Anyway.
Okay, well, thank you, Charlie. What we'll do is we'll take a quick 10-minute break and come back in executive session under ORS 192-660, bracket 2, bracket A, personnel, bracket C, medical staff, and bracket H, legal. So 10 minutes.
Oh, you, the people.
What's the difference between a quick 10-minute break and a